This chapter will discuss the schizophrenia spectrum disorders and other psychiatric disorders. So, the word schizophrenia means split mind, but forget the movie Split. This does not mean the person has a split personality. That's probably caused by a combination of factors, and it needs comprehensive, multidisciplinary effort for treatment. Um, I think we talked about this in recovery when we talked in week one, that even though some of these disorders are lifelong disorders, there is treatment and help for them. People who have schizophrenia have a reduction in their lifespan due to many factors of this illness. This could be up to 20 years in a reduction in their lifespan. And when you think about why this is, um, the medications have lots of side effects. Um, these people tend to be a big number of the homeless population, which puts you in danger in several different ways. Um, they have a tendency to use other substances to deal with the symptoms, especially if they're not compliant with their medications. So there's a lot of reasons for this. The schizophrenia itself counts for 0.7% of the total population. Sounds very small, but in Illinois, that's almost 9,000 people. In the United States, it's 12 million people. So, although the percentage seems small, it's a lot of people. And this is schizophrenia only. This is not these other associated disorders. Schizophrenia requires treatment that is comprehensive and presented in a multidisciplinary effort. This we need pharmacology, we need psychosocial care such as living skills, training, rehabilitation and recovery, and family therapy and education. Of all these illnesses, mental illnesses, schizophrenia probably has the longest hospitalizations. It's difficult to treat. It causes chaos in family lives. It a large cost to people and governments for the needed ongoing care. And the fact that a lot of these people are part of those marginalized populations who don't have as good a health insurance or no health insurance, maybe don't have support from others, and fear. Um, about 1 in 10 people with schizophrenia um, die from suicide. Um, there is a large stigma from having this diagnosis, so it can be detrimental to being able to get a place to live, to get a job, to work, to have normal relationships with others. So, psychosis. Psychosis is a disorganization of the personality, deterioration in social functioning, loss of contact with, or distortion of reality. There can be hallucinations, delusions, and psychosis can occur in mental health issues and in medical issues. Schizophrenia is disabling because it causes changes in your thought processes, your perception, and your affect. There are four phases. Premorbid phase is when the symptoms that you might see, but there's no clear evidence of any illness. Um, the person may become very shy, we withdraw from others, um, poor peer relationships, doing poorly in school, or demonstrating antisocial behaviors. Um, the age of diagnosis for these are usually late teens to early 20s for males, a little bit later for females. So, this is late high school, early college years. So we may see these kind of things as kind of warning signs, but usually people don't really pick up on these, maybe until later. So phase two, this can last from a few weeks to a few years. There's a deterioration in their ability to function. Um, then they will have maybe become depressed, not being able to concentrate, have some obsessive compulsive behaviors, and withdraw from others, from society. If recognized early, this is a good time for early intervention, and this can possibly cause, if you can intervene at this point, possibly better outcomes in the long term. Phase three is an acute schizophrenic episode. This is an acute episode. Um, there are psychotic symptoms. In your book, there is a box 15.1 and gives you the diagnostic criteria for schizophrenia. Some of the things are delusions, hallucinations, impairment in work, social relations, and being able to care for yourself. And then the residual phase is when the acute symptoms aren't there anymore, but negative symptoms may remain. Affect is flat, and impairment in role functioning are seen. So, prognosis, um, people who had a good premorbid functioning, a later date of onset, and female gender, which usually kind of go together. Um, The abrupt onset was precipitated by a stressful event. If there is less mood disturbance, and if the active symptom phase was short lived, then you're more likely to have a good outcome. Also, if you have no abnormalities of your brain structure, normal neurological functioning, and there is no family history of schizophrenia. So, what causes this? Well, um, it's still uncertain, although we have a lot of things that do point to this, but we can't say, oh, this is the single thing that causes this disease. Um, Genetic, there's a lifetime risk of about 1% of developing schizophrenia in yourself. But if you have um, a sibling who has schizophrenia, you have about a 10% risk. And if one of your parents has schizophrenia, you have a 5 to 6% chance. So obviously, there are some genetic um, causes here, although the exact genes have not been able to be determined at this point. Um, the dopamine hypothesis says that schizophrenia may be caused by an excess of dopamine in the brain or a increased sensitivity in the neurotransmitter, in the receptors to the neurotransmitter dopamine, having too many receptors or being more susceptible to them. There are other neurotransmitters: norepinephrine, serotonin, acetylcholine, GABA, and also some endorphins, prostaglandins, and other things that may be neuroregulators that are not are malfunctioning. Um, Excess in serotonin is thought to be responsible for both positive and negative symptoms, which we'll talk about later. Uh, and dopamine is linked to positive symptoms, and we'll talk about how you can tell the difference of those between positive and negative symptoms. Um, Viral infections, especially in a pregnant mother, during her pregnancy, can increase your risk of being diagnosed with schizophrenia later in the child. There are some anatomical abnormalities seen. Ventricular enlargement is the most consistent, although sometimes reduction in gray matter is also seen. Um, MRIs have shown that there's reduced symmetry in lobes of the brain and reduction of size of structures within the limbic system. So there are brain abnormalities that are seen also. We used to look at psychological uh, theories. Freud had a lot of theories of what caused mental illness. Um, they are not considered to be credible anymore, um, and probably came because we didn't have the ability to look at the biological connection as much as we can now, with new information and new abilities to look at the genes and the brain structures. Okay, so environmental factors. Um, there have been studies that have attempted to link schizophrenia to sociocultural factors, and poverty, for one thing, congested housing, inadequate nutrition, not having prenatal care, not having resources, and feeling of hopelessness about changing one's lifestyle of poverty. That is one thought. Another is this downward drift hypothesis, where the belief is the poor social conditions are seen because of the illness rather than a cause of it. Um, and one thing about this is schizophrenia isn't, will take anybody. It is not seen more often in people who have a family of poverty. Care may be less available for people who do not have money, and people who do have good social conditions may get better care. So that may be part of this also. Other things, stressful life events. Um, This can lead to exacerbation of the symptoms and increased rates of relapse. And I think that makes a lot of sense because stressful life events cause us to have issues, whether you have any underlying mental health um, concerns or not. When stressful life things happen, you are more likely to have some depression or anxiety, or it can, if you're known to have schizophrenia, you may have increase in psychotic episodes. Um, there are studies that show that if you have a genetic vulnerability for schizophrenia, there is an increased risk of psychosis, and particularly for adolescents with the use of cannabinoids. There's a lot of research done on teenage boys and the use of marijuana in their teenage years, and the fact that the thought is that possibly there is some thing that's turned on in these genes by the use of marijuana. And so it is considered to be problematic for a teenager to use marijuana unless it is for some very specific reason. So, other disorders include delusional disorder, and a delusion is a thought that is not explainable by any other factors. And you need to make sure that it's not explainable by other factors. Sometimes it's a cultural thing. There are cultures who believe things that if you don't belong to that culture, you may think, well, that's delusional, but it's not for their culture. So we also have to look at their level of um, intelligence. Do they believe things? How many people believe in Bigfoot? There are people who totally believe in that, and people who don't. So, um, is it a delusion or is it not? Who knows? But depending on the person's culture, they may be more likely to think of things that other people think are delusional. So there's different types of delusional. Erotomanic simply believe is someone who believes that they have a special um, um, love interest with you, and you may not even know that person is alive. This happens with famous people, than normal people who uh, they don't even know, who all of a sudden think they have some romantic attachment and may try to break in their house, um, contact them, and this person has no idea who they are. The grandiose type, where you believe that maybe I own large portions of downtown Peoria when they're a homeless person. Jealousy, where you think that your family or significant other is doing something and that makes you jealous. Persecutory, the FBI is watching me, the police are following me. And then the somatic type, where um, I I'm not alive anymore, my heart's not beating. And then the mixed type, where there's several different of these that you see anyhow. So a brief psychotic disorder starts suddenly. There may or may not be a severe psychosocial stressor, lasts less than a month. The person returns to the full premorbid level of functioning. You may see catatonic features. Catatonic features simply means that the person may be non-responsive, restless, posturing, um, and um, have waxy flexibility, which we'll talk about a little bit later in this um, discussion. Substance and medication induced psychotic disorders. Um, a lot of the medications, especially um, the amphetamines, can cause psychotic um, symptoms. Toxins um, can cause this. There's some medications, the smoking cessation drug, Chantix has caused psychotic um, symptoms in people who have no history of any psychosis. Um, these usually clear up after they're diagnosed and they either withdraw from the intoxication or they are not exposed to the medicine or toxin anymore. Steroids are another thing that can cause some psychotic symptoms in some people. And you have a list of substances that can induce this in your um, table 15.1 in your text. There are also medical things that can cause this, uh, infections, problems with your thyroid, um, Alzheimer's disorders. Um, Table 15.2 in the text also gives you a list of the medical conditions that can cause psychotic symptoms. And this can go from anything from head injuries to a neurological disorder. Catatonic disorder that is associated with another medical condition, including metabolic disorders, um, hepatic encephalopathy, B12 deficiency. And again, catatonia is restlessness, um, negativity. The person may have waxy flexibility, which means that they can be uh, positioned in odd and abnormal ways by another person, and they will maintain that posture until someone else comes up and moves them. Um, and So those are all things that can be seen with catatonic disorders. And again, those may be medical rather than mental health. Schizophreniform disorder is the same um, type as the brief psychotic reactions, except that they last more than a month but less than 6 months. We really don't want to diagnose anybody with schizophrenia. Um, once you are diagnosed with a mental illness, it stays with you for the rest of your life. So, schizoaffective disorder. These are all the symptoms of schizophrenia and having a strong mood element of either mania or depression. So, um, you may see a person who is very depressed, suicidal, um, has a very flat affect, psychomotor retardation, and all the symptoms of schizophrenia. Or they may be euphoric, grandiose, and very hyperactive. Um, so the mood disorder symptoms must be evident for a majority of the time in order to have the diagnosis of schizoaffective disorder. So the first thing that needs to be done is to look at what the contents of thoughts are. So delusions, we talked about. This is a positive symptom. A positive symptom is something that we would not normally find in the person when we are evaluating them. So delusional thoughts, loose associations, shifting from ideas from one topic to another with no connection, neologisms, which are made up words that have no meaning to anyone else except to the person who has made these up. Echolalia is repeating words or phrases spoken by someone else. There's also echopraxia, where the person repeats the movements of the other person. Clang associations are a way of speaking that rhymes. and kind of like in a poetic kind of thing. Word salad, and when words are just put together in a random fashion and they don't make any sense. Circumstance, circumstantiality, um, not being able to reach the point of communication because there's a lot of details, they don't make any sense. So it's just there is a trail to the conversation, but there's a lot of things that have nothing to do with where they're going in this point of conversation. And then tangentability, uh, can't get to the point of the conversation because you have a whole bunch of new things that you're thinking about. And, they're talking about going outside, and then they talk about, the trees, their trees outside. Um, their trees grow in the forest, and they just keep going to new topics, new topics, new topics, and you don't ever get to the point of what they wanted to tell you. And then perseveration, um, just a persistent repetition of the same word or the same idea, no matter what questions they are asked. Perception, hallucinations. Hallucinations are involved in the five senses. It can happen in any of the five senses, although in schizophrenia, it's more likely to be auditory or visual. Tactile is more likely to be in substance withdrawal, someone who is in alcohol withdrawal, who feels things crawling on them. The gustatory and olfactory are more likely someone with a head injury, brain tumor, but you can see any of these also with the psychotic disorders. And then illusions, misinterpretation of real stimuli. The person sees something, maybe they see an extension cord, and what they perceive is they see a snake on the floor. So there really are things there. So it's not a hallucination because there is actually something there, but it's not what they believe it is. And then echopraxia, which we already talked about. Affect, negative symptoms. These are things that you would expect to see in a person, but it's not present. So positive symptoms are things that you would not expect to see. Negative things are negative symptoms are things that you expect, but they aren't there. So emotions that are incongruent with the circumstances. Um, a lot of times there's a flat affect. There is um, no matter what they are talking about, there there's no change in their discussion, their affect, the face. So whether you're giving them great news or you're giving them really bad news, there's just that um, flat, no emotion. Apathy, being disinterested in the environment. Avolition. Avolition seems to means that you have no um, drive to perform any goal-directed activity. Um, this person may want to stay in bed. They may not take care of themselves, may not shower, may not comb their hair, may not put on clean clothes. All these things that are like expected things. They may not take care of any personal hygiene. Um, so things that you would expect the person to do that they're not doing. Lack of interest. So having behaviors that are not cultural and socially acceptable, um, intruding on the personal space of others, or being socially isolated. So, um, carrying a blanket and covering their head so no one sees them or they don't see anyone. Um, a lot of times, people with a psychotic illness have no awareness that there's anything wrong. Um, and so, if you don't believe there's anything wrong with you, you don't have a reason to take medicine to seek treatment because that's just part of the illness is that lack of awareness and it doesn't make any sense why somebody wants you to be in the hospital, why somebody wants you to take medication, um, go to groups, see a psychiatrist because you don't feel that there is anything wrong with you. And like I said, it's a symptom of this illness. Lack of insight, um, just not being aware, anergia, not be having any energy, ahedonia, no pleasure, and then the inability to abstractly think. So we may talk about concrete thinking. Um, Waxy flexibility, I talked about that earlier, positioning of the body, and then they cannot go back to the normal posture until someone helps them to get back into that. Um, Posturing, just voluntarily assuming a inappropriate or bizarre position. Pacing, rocking, regression, so behaving as though you're younger than you are. This is a defense mechanism and a dysfunctional attempt to reduce anxiety that the person may be feeling. Um, and then eye movement abnormalities, maintaining focus on an object for a long period of time. Um, and so, education. So the client and the family need education. Um, what to expect as the illness progresses, what the symptoms are, and ways for the family to respond to the behaviors that are associated with the illness. The management of the illness, what kind of medication management, um, who to contact when there is a problem, and they may need um, life life skills training. They may need training for occupational um, outputs, um, social skills. So there's just lots of different things that may be needed in the way of education. Medication. So they need appropriate medication management. Both the client and the family need side effects of the medication to know what those are, because especially with the psychotic medicines, there are a lot of severe side effects that need to be looked at so that they're aware of them and why it's important not to stop these medications. And again, this lack of understanding that you're ill, when we talk about all the medication side effects and all the things that can happen, people are, if you don't believe you're sick, why would you take a medication that might cause you to have abnormal movements, which may cause you to have sexual dysfunction, which may cause you to gain large amounts of weight. Um, that's one of the hard things with education. If you don't have that belief that you need these, then it's hard to get someone to be compliant. Um, when to contact the healthcare provider, and then just things to help. Support system, they may need financial assistance, legal assistance. Caregivers may need support groups. They may need respite care if this person lives with them. Home health care can also, for someone who is eligible for home health care, there are mental health nurses who do home care. So, things that they need to know about medications: don't stop taking your medicine abruptly. Be cautious when driving or operating machinery. A lot of the psychiatric medications are you need to wear sunscreen or wear protective clothing when you are outside because sunlight can have a negative effect. It makes you more um, likely to have sunburn, damage to your skin. Um, if you're taking clozapine is a really good medicine. It works on both positive and negative symptoms, but the person taking that has to have blood draws done every week for a certain portion of the time in order to get a weekly supply of the drug. It does, it's one of those medications. It's on a special um, method of um, um, watching the person. Um, I can't remember what they call it, but there is a protocol in place where you must follow all these um, instructions, and you have to have the blood test before you start the medication. Then every week it does get a little longer as you take the medicine longer, but in order to get this medication, you have to do this. Um, the big thing with clozapine, it can cause agranulocytosis, and if you remember from patho that agranulocytosis is a decrease in your white blood cells, especially the granulocytes, which protect you from infection. So that can be a big issue. Um, we want people to know that this can cause hypostatic hypotension. They can cause a dry mouth. Um, Smoking can change the metabolism of antipsychotic medications. So people who smoke maybe need their dosage adjustment adjusted in order to um, be able to get a therapeutic effect from their medications. And most antipsychotic medications are not recommended in pregnancy, although if the person is schizophrenic and is pregnant, medications may need to be used, and there are some that have been used that there's nothing recommended, but have less of a possible side effects to the fetus than others. We don't want people to drink alcohol while they're taking antipsychotic medications or consume any other medications or illicit drugs or over the counter drugs without talking to their physician first. Um, Many of these can potentiate the effect of the antipsychotics. They interact in a way that can be harmful. So, um, another thing that we want to recommend that person do not do. Um, and like using marijuana or other drugs. Alcohol is something that people use for a stress um, or to manage the symptoms. So, individual psychotherapy, um, long term therapy, and it's difficult because the person may not feel like they need long term therapy or any therapy whatsoever. Um, Cognitive therapies, group therapy, especially on an outpatient basis, things like social skills, diet and nutrition. Those are things that work very well in group. Acute treatment, inpatient stays are very short, and usually the person is very ill when they are inpatient. And so group therapy works less well for them, especially any involved talk therapy. Relaxation therapy may work very well, art therapy, those kind of things. But um, psychological talk therapy may not be very helpful in short term acute treatment. And then behavioral therapy, just sometimes teaching people what norms of behaviors are. Social skills training, um, cognitive remediation therapy, family therapy. Sometimes people may have a social dysfunction. It's very common with schizophrenia. So, kind of working with treatments that help that is very helpful to the patient. Um, this can be done in many different ways, but usually as an outpatient. Um, Involving the family is very important, and sometimes the family will be another homeless person. It may not be your biological family, um, but the whatever the support system that that person has. And then assertive community treatment. This is case management, and the ACT program comes from the Human Service Center here in Peoria, or Trillium now, I think it's called. And there is case management where the person has a case manager. They also have a psychiatrist. Um, they have maybe a therapist. They may have group therapies that they attend. They get their medication through this program. And the case manager will make sure that the person is getting food, that they're taking their medication, that they're getting to their um, appointments, and they may take them to their appointments if they can't get there on their own. Getting them hooked up with groups that help their social skills, living skills. So there's always someone on call in an ACT program. If your case manager is not on, there is somebody available and they can come to you or have you taken to the hospital if there is a acute problem going on. So there's always someone there for them. Recovery model. So again, we talked about this a little bit before. Um, so healing and transforming a person to live a meaningful life. And the meaningful life depends on what they consider to be the meaningful life. Um, Helps them to be independent, um, being able to function, being able to work, maybe go back to school, manage their symptoms, manage their medication. So all these things that can help a person live a meaningful life in recovery. This is just talks about recovery after initial schizophrenia episode, RAISE. Um, it's based on the National Institute of Mental Health, and It incorporates elements from other treatment approaches, community therapy, recovery model, family, and comprehensive care. Early intervention at the first episode of psychosis. And it's been found to improve care for this population, and especially when it is started very early in the onset of any psychotic symptoms. So, psychopharmacology, antipsychotic medications, um, neuroleptics, and they are effective for the acute and chronic treatment of schizophrenia and other psychotic disorders. Um, these medicines are also sometimes used in bipolar mania. Um, they are major tranquilizing um, drugs, olanzapine, quidapine, risperidone, ziprasidone. A lot of those are used. These are the atypicals or second generations, and they're a lot of times used to bring down that manic behavior quickly. Some of them have also been used as a adjunct for depression. And if you watch the TV drug commercials, you'll have heard about that. So antipsychotics are either typicals or atypicals, or sometimes they're called first generation and second generation. Um, the typicals are the older drugs, dopamine blockers, and these are the first drugs that were available. We did not have a drug to treat psychosis until 1950. So these drugs are fairly, um, in the medicine realm, fairly new. Um, the atypicals work less well with dopamine, but they also work with serotonin. And so they work on the positive and the negative symptoms. The typicals do more for the positive symptoms, the hallucinations, the delusions, than they do for the negative symptoms, the apathy, the flat affect, things like that. Side effects. There are lots of them, as you can see here. Um, you're going to be given or have been given a psychiatric emergency handout, and that will talk about some of these, the tardive dyskinesia, the neuroleptic malignant syndrome. You also have information about extrapyramidal symptoms in your module this time. But there's a lot of other side effects, um, anticholinergic side effects. So the dry mouth, constipation, nausea, GI upset, skin rash, sedation. Sedation can be a real problem, especially if medicines are given through the day. Orthostatic hypotension, photosensitivity, hormonal effects. Some of the atypicals can cause breast development in men, can cause milk production in a non pregnant female. Neither are seen as positive effects. Changes in the electrocardiogram. So some of these medications affect the EKG more than others. So for some of these, the person needs to have an EKG periodically to make sure that there hasn't been um, problems there. Hypersalivation or drooling, that can be very um, detrimental to a person if they are drooling. Weight gain, the atypicals, sometimes that can be up to 50, 75 pounds in a fairly short period of time, which obviously is not helpful. Hyperglycemia, diabetes, the increased mortality of elderly clients with dementia, reduction in the Caesar threshold, agranulocytosis we kind of talked about, and then the EPS, tardive dyskinesia and neuroleptic malignant syndrome. So pseudo-Parkinsonism, those are the symptoms of Parkinson's disease, the shuffling gait, the tremors, akinesia, akathisia, dystonia. Akathisia is a restlessness. The person feels like they can't sit still and they may pace constantly because when they sit down, they're very uncomfortable. So they're up and pacing. Um, Dystonic reactions or oculogyrocrisis. You have a video in your module of a child who's having a dystonic reaction to um, I think it's I think it's risperidone that child is taking, and it shows you how that is treated. Benadryl is a effective treatment for that. The ocular gyric crisis is the eye muscles are involved. Dystonic reactions can be, they're definitely concerning to the person, but they can be a real problem if it happens to involve the muscles in the throat, and it can cause problems with breathing. Anti-Parkinson's agents can be prescribed for some of these things. Um, those include Cogentin, Artane, and Benadryl can be used. And if you'll look at there's also a man who has tardive dyskinesia that I put a video of him so you can see what those movements look like. If you happen to have someone in your clinical practice that has had antipsychotic medicines for a long time, you may be able to see these symptoms of um, tardive dyskinesia, akathisia, um, or you might see akathisia in the hospital because that can come on fairly quickly. Somebody new started on um, a drug and just have that restless feeling that they can't manage. And that's pretty much it for this. We'll talk a little bit more about this in class, but this is the recording.